Okay, so I'm going to talk about the Lisfranc fracture, and then we'll get Dave Shear up for a video on the Pilon. So Lisfranc fracture, I think we did in the lab. I think most of you went through the lab and looked at some foot fractures, so that's good. There's my disclosures. And really, it's quite a rare injury. It's up 2%, so it's usually a lot of them are, series are quite small because of the rarity of the fracture. Anatomy, you can go through is, we're not going to cover this part of it, but the idea is to look at how to diagnose it. It's really a one that if you can diagnose it, fixing it's not that tough. So you look at the straight, unbroken parallel line with the medial edge at the base of the second metatarsal with the medial edge of the medial cuneiform, and both the anterior and oblique projections. So if you can look at that and follow that along, then that's unbroken. You can convince yourself there's not much of an injury. And the other one is the medial aspect of the fourth metatarsal, should be in line with the medial edge of the cuboid. And a step off of 1 to 2 millimeters may be a normal variant, but the lateral projection is important to have a look at that. So classification, Kuhner and Kuss had 3 types, so homolateral, isolated, and divergent. I'll go over those. So homolateral is 5 metatarsal displaced in the same direction as you can see here. So that's clear. Isolated is either the first or the second is displaced from the other. So usually the first one's pulled out, but you can also have some where the second is just popped out the back and moved medial. So again, it can be either where they're isolated. And divergence, like I had my first job in New Brunswick was working on a road crew, and as I was finishing up the road crew, I was like 18 years old, and this guy put his foot up on a trunk and took an axe and went right between his first and second metatarsal. And I said, "What are you doing?" He said, "Well, I have no job and I have a big family, so I got to go on workers' compensation." So that's what he did to himself at the time. So I saw a divergent right off the bat in the first part of my life. So it was true divergent. So. Anyway, the oblique X-ray, that was a very important X-ray in this particular fracture. It opens up the base of the lateral metatarsal, and misalignment of the first metatarsal is best seen in the oblique X-ray. So you need to get the oblique X-ray, not the AP and lateral. So significant pain and swelling, that should be the key. A lot of them will present to your clinic. They've been seen in emergency, and you're trying to make a diagnosis as to whether this is a true fracture. Now, here's a stress view you can do to stress the first MTP. See if your first metatarsal tarsal joint, and then you look at these. You draw a line along the navicular and the first cuneiform. You can see it intersects with the first metatarsal, but this one falls off laterally. And some pes planus deformities can do that, but this is a good indication. If the normal foot does this, the second one should do it as well. So have a look at that. So this is looking at another patient with a bony Lisfranc. You can see here the CT scans we talked about before will be sometimes the only one that picks up the injury. You suspect it, you do the CT, and there it is. You can do with weight-bearing films or have a look at it. And these are fixations. You can do parallel screwing. You can do divergent screwing. And usually all of us now use mostly wires in the lateral fourth and fifth metatarsal. You can take them out at about the 6-week mark. We'll go over some of those. So really the question in most, when you look at Lisfranc fractures is, do you fuse it or do you just fix it? And so anti-displacement and multiplanar displacement should be a cue that maybe a fusion might be indicated. But for the normal one, I think primary open reduction internal fixation is good. So fusion is good. Several authors, including Henney, Lai, and Coetzee, have done short term studies comparing primary arthrodesis with open reduction internal fixation. Pretty stable, not really much of a change, but they feel it's important. It is a more complex operation, so if you're going to do a few of these, I think I'd just stick to open reduction internal fixation, get them stable. If they have pain down the road, you can always fuse them down the road, but it does make the operation a little more complex. So, however, if you have someone that presents late to you, so the guy that presents at 6 weeks or 8 weeks with a deformity or a chronic untreated one, those ones need a fusion. You can't just go back in there and do an open internal fixation with the articular surface intact. You won't get the fixation that you want. You won't correct the deformity. So those are the ones that we all agree. So multi-ligament, so if it's going plantar and dorsal, if it's a late presentation, or if it's a chronic untreated one, those are the ones that need fusions. The rest of them you can treat with primary open reduction internal fixation. Many people look at this reduction and they say you need to get it perfect, and I believe that. I'm one of those. And you look at this primary open reduction versus fixation with delayed corrective arthrodesis. Both of them were done well, but they didn't have the same results. So you look at them, the American Orthopedic Foot and Ankle Society midfoot score at 36 months with 81.4 for the initial open reduction internal fixation. But the delayed group that didn't have it, it was only 71.8. So I think the conclusion here is if you recognize it, and we should in this room, then you should treat it effectively in the corrected position. So if you think it's missing or displaced at all, then open reduction internal fixation is the treatment of choice. So most authors agree it's imperative to achieve precise anatomic reduction. If you don't feel it's perfect, then make it perfect. Here's another patient, 59-year-old firefighter, needs his foot, of course, got a homolateral fracture, fixed with screws in the first, second, and third metatarsals, then K-wires removed in the fourth and fifth at 6 to 8 weeks, and non-weight bearing for 12 weeks. So 9 months post-op, looks pretty good. And the big question here for all of us now is, do you take those screws out in the medial column? So you have it fixed, he's having no troubles. Do you leave it alone? Do you wait and see if the screws are going to break? So another patient, 18-year-old patient, slip and fall. You can see divergent type of injury and a fracture through the base of the fourth. First one's off. You can see a nice fixation, getting it all into good position, and stable fixation in the medial column, and then more mobile fixation laterally. So 6-week follow-up. And we really want, I just want to emphasize, we really want anatomic reduction. When you go and do these things, you want to get it so it's perfect. So how do you get that? Well, operative setup, you kind of slide the patient down the end of the table so you can bend his knee, bend his foot so you can get the x-rays that you want. And dorsal incisions, I just go more toward the second than the first, so they get to both of them through that, and then lateral incision over the fourth ray to get to those if I need to. So this provides access to the base of the second metatarsal, and it's a usual site of obstruction. You really find fragments and soft tissue, and then you have to get them out of there to go through. So this is accurate anatomic joint reduction. It's essential. You can see here displacement. We get it reduced, then you pin it, and then you can put your screws in to follow. So always do provisional pin fixation and follow that up with stable fixation. You can do that with regular screws or cannulated screws. So provisional wire fixation and the unstable metatarsal, then fixed to the tarsus with 4.0 or 3.5 millimeter screws. So this is the entrapment of the fragments in the joint, as we saw there, entrapment of the soft tissue. That's why you can't get the reduction. So you really can't do it percutaneously if they got a lot of significant displacement. So open reduction, small incisions, it's not hard to get there. For the things that we normally approach, this is a pretty easy approach. It's just making sure it's perfect. So Arts and Hansen first presented, they recommended removal of these screws once stable, and that's been the big challenge is, do we still have to remove them or not? We have a firm study at the COTS group where we've had them all enrolled. We just have to follow them out for 2 years and see if the ones we take out, we did divide them in half, so half got them out at 6 months, half didn't, and hopefully we can give you that answer, or at least part of the answer, when we get that final follow-up done in a 2-year mark. So lateral column of the foot was felt to be too rigid with screw fixation, so we've gone to K-wires for most of us. Although it's still, if you can't fix it, and you don't feel you have good stability, putting a screw in is okay, it's just you got to take it out, that's all. You just can't leave it. So 21-year-old male hurt his right foot, and this just goes for pre-op planning. You can see the injury, investigations, significant bone injury here, and you can see 3D is always a nice treatment plan. Medial Lisfranc, you can see what you want to do on the medial side, Lisfranc joint, and the lateral side. And how should we rehab the fixation? And you can see post-op treatment at 6 months, doing pretty well with everything out. 18 months, again, they get some motion, I think, at these by taking everything out, but we don't know that. Final one I just wanted to go through quickly, look at the pre-op planning. Try to plan what's needed to stabilize the fracture ahead of time, and then try and compare what you did. So here's what we did to the foot post-op at 8 weeks, and you can see comparing the pre-op plan and the post-op, you should try and look at that. And you can see we used a screw in the 5th metatarsal, but we took that out at 6 weeks to get that more mobile again. So at 8 to 10 weeks, the cast comes off, lateral screw and wire removed, progressive weight bearing allowed, arranging the ankle, and then plus removal of medial column at 6 months. Maybe, maybe not. We'll hopefully see going forward. So we've got more unsatisfactory results. And the medial column was disrupted, and these just goes back to Arntz and Hansen's report that said you should take them out at 6 months, but we don't all do that at this point in time, but hopefully we'll have an answer for you. Conclusion, therefore, at this stage, the conclusive evidence from the literature would indicate that open reduction internal fixation should be done with rigid fixation the first through the third, and then mobile fixation laterally, taking it out early, and hopefully we'll find out what to do with the medial column as we go forward. But in the younger patients, I certainly try and take it out, as if they're older patients and they have a a stable mid-column, no motion, no screw fracture, and no pain, I leave them alone at this point in time. So thank you very much. And any questions? We'll go to the panel. So Dave?